So I would love to take this opportunity to introduce our speakers, Sloan Costello, Andrea Braundorf, and Allison LaRocca.
Well, what a lovely presentation that preceded us. It was absolutely beautiful. Thank you. We are very excited to be here and share a little bit about what we do at the jail. So we're going to provide just a little overview of our jail system, the population that we serve, and kind of how the jail is laid out. We're going to talk about needs of care, access to care, and then levels of care in the facility. And from our lens, the mental health team is fairly focused on severe and persistent mental health issues. So we're not doing ongoing therapy, it's crisis work, it's getting people on medications, and working with a population that is on suicide precautions. So.
Thanks. Okay, so I figured we'd start off with a little bit of kind of what does our population look like, who's in the jail. I don't know if anyone, well actually I know of one person in this room, but has anyone else been inside of our jail? When I said one person, I meant because I just found out she used to work in our jail. Sorry about that. So a couple people, okay. So for those of you who have not, I figured this might be kind of helpful to give just a little background of who we're talking about today, and kind of structurally, what does our building look like? So just for some numbers, our max capacity of the jail is around 525 individuals. And that is, assuming that we can have individuals that are, 2 people in one cell, which is often not the case in our current population. So current capacity right now kind of fluctuates week to week. Right now we've been kind of sitting around 450 to 475 individuals, which is pretty full. Yeah, it's pretty high. Within those 450 or so, I wanted to highlight that about 10 to 12% are female individuals, and when I say that, I do want to recognize these are individuals who are biologically female. We do have a small population of individuals who identify as transgender that may not fall into, that specific percentage that I'm bringing up. So current capacity of those 450, about 88 to 90% right now are pre-sentence, pre-trial. And if anyone is familiar with kind of the court system or the jail system, that's absurdly high of a pre-sentence rate inside of a jail. Basically, those are, there's 90% of people in our jail right now who are charged with something, but they are not convicted of anything. Our system is innocent until proven guilty, so that's how many people are sitting in our custody right now, just waiting for their case to develop, often for weeks, if not months, sometimes upwards of a year. And so when Sloan and I were putting together this part of the presentation, we were trying to come up with some numbers as far as who is actually, who are we talking about today? Who's struggling with their mental health, with a substance use disorder. And it's difficult to get specific numbers. As I'm sure you guys know, these things are often underreported by individuals. But we were able to kind of come up with around approximately 75% of individuals in our custody struggle with a mental health condition or a substance use disorder. But I would beg to argue it's probably a little higher. So kind of in general, our jail sees charges that range all across the board from the lowest level municipal charges to the highest degree of felony charges. So we may encounter individuals who have been arrested on trespassing charges all the way up to individuals who have been arrested for charges of a double homicide, really, and anywhere in between as well. So jail sentences in general are generally 2 years or less. However, we have been seeing where, someone might be sentenced, might receive multiple 2-year sentences, which then they would stay in our jail a little bit longer. And the reason I really bring that up is typically if somebody receives a sentence that is longer than 2 years, that's when they would transition to a prison sentence through the Department of Corrections. Their settings are a little bit more set up to have individuals live there long term. Our jail is generally not a long-term facility. We're just not set up that way. So the quality of life definitely differs the longer that we have people in our custody. And then also what we're seeing right now as far as in general in the jail is really, really long wait times. Not only do people wait and wait and wait to, get through their case, but then once they've finally been sentenced to, let's say, a community-based sentence or treatment, then they often wait even longer for a bed. So further contributing to kind of the overcrowding in the jail and just not ideal situations to just have someone sitting around. And then as far as structural for the jail, so we have the building's kind of separated into different buildings, but if you go into the jail or those who have been in the jail, it kind of just feels like one large building. So it's broken down and I'll briefly go through. So building A is where we house our highest level of mental health acuity individuals, and also, our highest level of individuals with criminogenic history. And then we take a step down, we have building B. That is where we have our intake module. That's kind of like the first stop where everyone goes once they've been booked in. That's kind of where we're determining level of need, which someone will talk about, determining their classification level, determining their criminogenic history. And then we have our general population unit. And then we also have, kind of an overflow mental health unit from building A. That's only recently and probably the last year that we've had to kind of shift from 2 general population modules to now, our population has shifted. We have a lot more individuals struggling with their mental health. Kind of had to make room for, our lower acuity mental health individuals. And then we have our building C. So that's kind of our dorm setting. Individuals are workers here. They work in the kitchen, they work in the laundry, cleaners all over the place. And they're also often engaged in our jail-based programming. And that's like kind of our least restrictive environment that we have here.
So in identifying who needs help, who needs assistance, we rely heavily on our deputies. We rely on our security team. So an arrestee comes in from the community, and like someone pointed out earlier in talking about community, arrestees, the people that have to stay at the jail, are our community members. So I think that's important to remember. So somebody comes in, the arresting agency enters our booking garage. It's the individual is removed from the vehicle, and there's a pat-down search where deputies are looking for contraband, drugs, weapons, and that's the first kind of real point of contact with staff, and there is a real brief suicide assessment. So they are asked about, the individual is asked about any current feelings of suicide, any recent suicide attempts. A positive answer there, and an answer in the affirmative, will place that individual would be placed on suicide precautions and seen by mental health, seen by one of us within the first 24 hours of their arrival at the jail. And there's a special protocol for people that are experiencing suicidal ideation in custody. So the next step is they're brought into the booking area. That's just sort of a large seating area. There's lots of action, there's lots of deputies around, and that's when deputies really begin to assess their behaviors. So if anything out of the ordinary is noticed, there is documentation created and referrals generated to our team. Every individual that comes into the jail is it's like a medical mental health screen within 4 hours of their arrival at the facility. The booking process takes 1 to 4 hours, just depending on how busy the team is. The individual would then be dressed into the jail, and they would go back to the intake module, which again is a high observation unit. Deputies are documenting behaviors, again, where referrals are generated. In that intake area, what is really happening is our classifications team is trying to identify the safest housing, the most appropriate housing within the jail. There's a classifications interview that takes place. So part of that interview is also a suicide screening. So during the initial intake, during the medical screening, and now with classifications, there's been three suicide evaluations within the first 5-6 days of being in the jail. Excuse me, I need to get a drink. Thank you. The thing that I really want to point out is relying on the security staff to observe the individuals that are staying at the jail and documenting their behaviors and making said referrals to the mental health team so we can get them in the appropriate level of care. The other thing that happens is somebody comes in during the arrest, they underreport any mental health symptoms, they're angry, they're maybe in withdrawal, so they're not really present, they don't want to engage with us. So the vast majority of our referrals are actually people who kind of start feeling a little bit better, kind of get through that first phase of jail and decide that they want some help. And so again, we would see those people as quickly as possible and refer out to an appropriate program if they weren't high acuity.
So I will talk a little bit about access to care now that we've just kind of told you about how we identify that actual, the need. So first and foremost, all individuals in our custody have the right to mental health treatment. And also with that said, all individuals also have the self-efficacy regarding their care. And the reason that I bring that up is because a lot of our clientele, not a lot, but oftentimes our clientele will refuse treatment. And that is absolutely their right. The jail has no legal ability to force any kind of treatment on them, mental health, medical. If somebody does not want our help, we cannot force meds, we can't, do anything that they don't want. Even if somebody comes to our custody on court-ordered meds, short-term, long-term cert, we still have no capability to require them to take their medications if they do not want to. And sometimes that's not necessarily somebody who is, being hostile, no, screw you, nothing like that. But sometimes it's just that people don't have maybe they don't have the ability or the capacity to understand the care that we're offering and to be able to accept that care. But with that said, there's also a lot of individuals, most individuals in our jail who do want treatment, who do want some help. And so Sloan mentioned, some self-referrals. That usually looks like someone sending us what we call a kite, which is kind of the jail snail mail communication. So someone might send a kite. We would put them on our mental health referral list. Every day we sort that referral list based on referral date and level of acuity. So patients with a higher acuity are often seen by our team either that same day or the next day very quickly. But we do try and kind of make sure we get to the latest or latest referral that we have, while also recognizing there are some times where we might have to prioritize somebody who is experiencing severe psychosis and hearing voices that are telling them to hurt themselves or hurt others. We may have to prioritize seeing that individual versus somebody who's been waiting a little bit longer, who is maybe struggling to sleep in this environment. Not that they're struggling, just a different priority level. So as far as our mental health staff, our team goes, we have mental health staff in the jail 7 days a week. Our clinicians mostly, we have 4 clinicians. They work typically 8 a.m. to 6 p.m. Just in the last few months to a year, I recently started extending, doing different hours, so I work until 9 p.m. so that our night shift staff has a little bit of support. Then we also have 40 hours of prescriber time split between 3 different prescribers. And then we also have on-call as needed throughout the night. And then we also are very fortunate, outside of just our mental health crisis team, to in our jail have many different jail-based programs. Oftentimes a jail may have 1 or 2 programs. We have upwards of 8, and I'm probably forgetting a handful on there as well. So I won't go into too much detail on the different programs. Allison will talk a little bit about hers in a little bit, and I know that there's a ton of acronyms. That's typical in our field. But a lot of them are, substance use centered or substance use and mental health centered. They work within the jail. They often can follow people outside of the jail. But even with a lot of these, a lot of the support that we do have within Boulder, I think in any facility there are gaps to access. So, one of the biggest gaps, or I guess one of the 2 biggest gaps that we've identified are individuals who are maybe experiencing, their mental health is maybe too acute to engage in some of these programs, yet they're still getting released back into our community and need support. Or individuals who maybe have more serious charges, and so maybe they're not returning to the community right away. So again, not eligible for these programs, but still wanting support to manage their time in the jail. Those are 2 big gaps that I've been working on developing a proposal to create a new program in our jail. Slow process, but we're getting there, to try and fill some of those gaps. But yeah, I think everyone is well aware there's always gaps when we talk about access.
I'm glad Andrea mentioned the program that she's in the process of creating. So one of the things that happens in any of the jail programs is that the individuals in those programs get good time. Sometimes that can be up to day to day. So if they have a 60-day sentence, they can get 30 days off their sentence for participating in these programs. One of the big holes in the system is that somebody that experiences serious mental health issues doesn't have access to good time. So Andrea's identified that gap, and hopefully we'll be filling that soon. So in determining level of care, the jail has a written policy of least restrictive environment as possible. So if somebody can be working, we want them working. If somebody can be in the dorms, we want them in dorms. If somebody can manage themselves in general population, we want them in general population. Unfortunately, not everybody can manage themselves while in custody. So as Andrea mentioned, and I will mention again in a moment here, not being able to force medications is a significant barrier to treatment. So when someone is not thriving in a structured environment like the jail, that means they're doing pretty bad. So again, people experiencing acute psychosis, manic episodes, unable to care for their most basic needs, eating, drinking water, toileting appropriately. When this happens in our facility, it's really difficult to sit there, watch, and have no tools. And that's really where BCH comes in. So we've been developing and refining a process of sending people out on involuntary holds while they're in custody to get them started on treatment. And if we can break that cycle of mania, if we can break that cycle of psychosis, we've seen people come back to the jail really, really well. Sure. Can I do that in a moment? Thank you. So how we decide if somebody meets criteria for an M1 hold is we staff the case as a team. We kind of come to a consensus, make sure that we're all on board with this process of sending somebody out on an M1 hold. We'll identify the level of care that they need. Do they just need to go to the ED for emergency meds? Do they need longer term treatment? Are they eligible for longer term treatment? Like Andrea said, we have people in custody for murder. No judge is going to give us a bond, a temporary PR bond, with that charge, right? So we have to look at kind of the whole picture. Once we've decided that this person is going to be sent, we start working with the emergency room. We'll work with BCH's TLC team, and then we start working with the Della Cava inpatient unit to identify if there's an appropriate bed available. Oftentimes we can delay sending somebody out for a day or two if we think that a bed is going to be coming available. We've been successful with this process, and again, it's something that needs to be continuously refined. The other thing that we need to do is when their sentence is terminating or they're bonding out, if that person is not safe to return to the community because of their mental health, that person again is evaluated, and if they meet criteria for an M1 hold, the jail again would send them out. That's a little less of a difficult process because they're no longer in our custody. This one? So to answer the question around being unable to comply with court-ordered meds, we're not a 2765 facility. We're not licensed in that manner. And so it is legally impossible for us to force medications. It is a huge barrier. Somebody comes in, is really, really acutely ill. We send them to the hospital. We see them get better. If we don't send them to the hospital, they languish. It's difficult watching people with mental health suffer in jail. It's a place where without help, they don't get better. So in looking at our challenges, this is the most significant challenge for our facility in working with people that are acutely mentally ill. Running out of water here. So again, we look at that person that we send out on an M1 hold, they return, they're doing better. They can choose to stop taking their meds and decomp days, weeks, and be right back in the same process. So again, that not being able to administer meds is really, really frustrating. And it's a question that we get when we send somebody out. How come you don't medicate them? Well, thank you. We would if we could. Another significant issue is the competency process, and we could get into the weeds with this. I will simply say that when somebody is found incompetent to proceed by the courts, it can delay their treatment or delay their stay in jail by up to a year or more. So somebody that has no mental health issues gets arrested on a shoplifting charge, they could be out of jail within 24 hours if they have financial resources. With no financial resources, they could be out of jail in a couple weeks. If that same individual or an individual with mental health is found incompetent to proceed, they could be in custody for well over a year for a simple charge. The good news is the 20th Judicial District, Boulder County Courts, now have a specialized court, a competency docket. So these issues are being addressed. The docket started in September, so we're only a month into the program. But I'm really excited, and I think that we will see some movement here in the near future with that problem. Lack of meaningful resources, right? So we're expecting somebody that's mentally ill to be able to get out and navigate complex mental health systems, to walk, 3 miles to MHP's facility, to have their appointment that they have to wait 3 hours for. There's a lack of meaningful resources in the community, specifically around housing. So how can somebody be stable without safe housing? And emphasizing that these individuals are our community members still. Lack of meaningful resources, difficult to access resources leads to recidivism. So I think I saw Grant earlier. I was talking to him last night about the high utilizers group. We have a handful of people in our community that utilize jail, hospital, and other resources, taking up valuable time, law enforcement's time. So if we can start to, as a community, start to look at some of these things and provide easier access to meaningful resources, I think we could, again, start to see some differences. The last thing that I want to say, when I started at the jail 8 years ago, BCH's mental health facility was at 3 North. There was no relationship with the jail. There was no mechanisms or processes to send people for treatment. Della Cava being 5 years old, in that 5 years, we've really developed positive relationships with the emergency department, with the inpatient treatment center at Della Cava, and they have been real partners in helping these people that need help. So it's been exciting to watch that grow, and I think that we're going to continue to work well together, and hopefully keep on keeping on.
So this is Sloan and I's contact info. I know it says questions, but we'll hold them till the end, until after Allison's done. I forgot there was a microphone. The last thing that I just wanted to say too, and Sloan's mentioned it a couple times, but I just wanted to, thank everyone thank, the people who put this on for inviting the jail to come and speak. There was a different presenter, I wrote it down, I cannot remember her name, but she said, we can't have healthy communities without healthy individuals. And I think oftentimes our incarcerated folks are a forgotten part of this community, and they are a huge part of this community. So I appreciate, the individuals who ran that. I think, Amanda was a big part of, getting presenters. And so I appreciate you recognizing that this population is one to be heard too. So thank you guys.
Hello, I'm Allison LaRocca. I am the JMAT Opioid Program Coordinator at the Boulder County Sheriff's Office. And our Health Services Administrator was planning to be with us today to talk more about the JMAT program, which she is the architect of, but she's quite ill. So we will do so without her today. And so just a quick program timeline. So when this program was being developed, it goes back about going into 9 years now. Narcan became available in the jail in 2016 for overdose reversal. In 2017, we introduced naltrexone or Vivitrol. It's offered for opioid abuse, not as successful, and currently we do not prescribe it for opioid abuse. We prescribe it for alcohol, much more effective with alcohol use. And methadone began continuation of prescriptions in 2019, and that's also when we introduced Suboxone, sublingual strips, into our jail. In 2020, during the epidemic, Melanie, our Health Services Administrator, determined that we would be better off offering a long-acting injectable. Less diversion, less stress on our staff, and during the time it made a lot of sense. We've had quite a bit of success introducing the long-acting injectables, and in 2024, Brixadi is the new medication, and we are working through the process of transitioning to that fully. We do have some patients that are remaining on Sublocade at this time. Okay. All right, so our MAT program is comprised of about 3 phases. Sloan and Andrea talked about the initial when they come into custody and they're in that booking environment. Our medical staff is screening them, asking them about, are you going to withdraw from something? Are you using alcohol? Are you using fentanyl? Are you using something else? During that process, they're going to be placing them on whatever withdrawal protocol is most appropriate for them. When they're identified as opioid users, they're going to be screening them using the COWS assessment, the Clinical Opiate Withdrawal Scale. Individuals that are meeting the criteria associated with that assessment are then going to be inducted into the program. Once they are inducted by our medical team, they refer to me as the coordinator, and then I take over from there. We have individual and group therapy in partnership, myself and an agency, CJS, Community Justice Services, Comprehensive Opiate Abuse Program, or COPE. We partner for treatment together and reentry. And so what we try to do with our JMAT population is really treat the whole person. So we want to provide them medications, we want to provide them access to clinical work, treatment, group therapy, contact with communities, and then reentry services. How can we do continuation of care in the community? What's going to be the best fit for them, and what do they need? So we talked a little bit about this, the COWS screening criteria. They have to give their consent, so we cannot force people to be on medications. They also have the right to refuse participation at any time. It's not mandatory that they continue in our program. It is encouraged, of course, but it is up to them as the adult individual to make that decision. And so this is our phase 1. We talked about that. So one of the things that I do is every single day I'm keeping track of every person that comes into our custody that is in withdrawal. I keep a tally of this. I document this, and then I also encourage cooperation with our screening process. It can be very difficult for them to want to cooperate. They feel absolutely terrible. So they've been using substances for many, many years, and once they've started using methamphetamines, that phenomenon specifically associated with the dopamine dump of methamphetamines changes things for most of them. I would say all, probably. They're using those together. Fentanyl and meth are BFFs. We see them in concert all the time. And so because their brains don't make their own dopamine anymore, that's the first thing that falls away. And then their teeth wake up, and then their emotions wake up, and they hate all of us, and they hate themselves. And so it's very, very difficult to get them to engage with us because they feel so terrible. Their body is rejecting everything. They can be very difficult to work with. So our custody staff is really encouraged to let us take this side. Like, I will go in and have the conversation. Mental health can go in and have that conversation. Please cooperate and let us help you. They feel terrible. Everything that they've been pushing to their toes is now punching them in the face. It's a very, very hard time for them. And so when I'm dosing those individuals, that's my luxury, is that I get to dose them, even though it can be half my day sometimes if there's a lot of them. The largest amount I've dosed in a day is 11 individuals, but then all of those people I get to talk to, and I get to talk to them about the program. I try to build some rapport with them, encourage them to reach out to mental health if they're starting to really struggle because they can't sleep a lot of times. Mental health handles our sleeping assistance, right? Getting them to advocate for themselves when they don't feel capable of really anything is a super challenge. And so when I'm evaluating them, I'm trying to build rapport with them in that beginning stages as I'm giving them medicine so that they're more comfortable and willing to talk to me, give me an idea of what they're trying to manage. And then those individuals who are at moderate to severe opioid use disorder, we're going to keep in program, and we're going to offer them the transition to the injection. They do not have to transition to the injection, but we do not provide long-term Suboxone. So they are then taken off of Suboxone, and they can restart in the community. And sometimes they're just not ready at all, and it's okay. And it can be really challenging for our custody staff because our jail is very full, not designed for the large amount of humans that are residing in it on the regular. And so they're like, this guy again, or this chick again. And I'm like, they're alive, thank God. Nobody knew where they were, so then we can try and reconnect them to their community people. Thankfully, we have some great case managers and social workers in programs that have been looking for them possibly. And so we try to reconnect, get them resourced again, what wasn't available and what do we need to do next to try and help them be more successful. Okay, so therapeutic intervention. COPE, which is the program that we have through CJS, was brought over in the beginning stages of the program by Melanie when she was creating this in collaboration with the county to provide our treatment work. Our individual therapy is handled by COPE, and then the group therapy is in partnership. We provide numerous groups throughout the jail. We also run a women's program. Unfortunately, our jail has 2 places for our ladies to go, and it stinks. So what we try to do is provide them support and access in the women's module, which can have all levels of individuals, a first arrest to somebody that is super high acuity, that they're fighting to try and get somewhere, and they're terrified children, basically, teenagers, just 18, 19 years old freaking out in there. So we try to give them additional support because we only have one other place, the dorms. And when the dorms are full and the women's module is full, it can be very, very challenging for that population. One of the great things about our treatment programs is they really are starting to build those communities. Our unhoused population is the bulk of who we see in custody. They know each other. They have the most intricate trauma bonding that you've ever seen. They save each other, and they resuscitate, and then they help each other, and they stand in front of everybody. And the communities are so deeply woven, right? So if somebody overdoses and passes away in the community, the jail then is going to feel the ripple effect of that because these are their people. This is their family. And so it's very difficult for them to process the loss, the profound loss of life that they go through and try to mitigate themselves before they get help. And so we really try to create safe spaces for them to process that. There is so much trauma that they're trying to manage all the time. And it's very, very hard for them in the environment that we have. So that's one of the things that we try to do. And of course, we have limitations, which can be challenging. So with reentry services, 60 days from release, we're really trying to get those people connected to what is next and what do they need more of. Associated with my JMAT program, so JMAT is me, I'm one human, standalone program, and I partner with COPE, which is 2 other humans, my clinical partner, Elaine, and then my reentry coordinator, Gabby. So what we do, the 3 of us, is we try to engage continuation of care in the community. We try to, if they're going to be working with probation, if they're going to community corrections, can we get them started if they weren't inducted when they first arrived? Can we make things available to them? Do they have the ability to get a bicycle? Can we help them with clothing and access to housing? We do have some housing partners that we work with, but obviously things are limited. If the individuals that are released are working with reentry, they can work with them for up to a year afterwards. But the hard part is being unhoused. It's very difficult to get people to show up at certain places, and so there's an awful lot of outreach that happens in the community. Some of our partners, BHAP and JET, they go out into the community and try to engage those individuals once they're no longer in custody. And then they come back and we reconnect them again. Okay. So for the individuals who are not inducted upon arrival, so these are the people that either they refuse to work with our medical staff at all, which is their right, but it also does prevent them from getting access to Suboxone, because if they can't properly evaluate them, they're not able to provide them with that medication, and that can also be very challenging. They can send requests to me, mental health or other programs can refer individuals, and then we will look at, is it appropriate for them to get started before they go, and do we have a release date? Because we don't have that option for long-term Suboxone, we need to have an end game where we will, because it's incredibly expensive to transition people to the long-acting injectables. We spend between $50,000 to $60,000 per month on long-acting opioid injectable medications. And so we try to get them engaged and staying in program as much as possible. 6 days before they leave, we can induct them and get them ready so that they're at a therapeutic level when they leave custody, so they can make that choice either with their probation or whoever. I'm going to continue Suboxone, or I'm going to do the transition to the injection, or I'm not going to do any of it, because they are adults and they get to make those choices. One of our benefits is harm reduction. So Boulder County Harm Reduction is a very strong partner. I partner with 2 ladies from there, and we do group harm reduction trainings within the jail. They come in and they do STI testing, hepatitis C, HIV. A lot of syphilis is coming back, so we are introducing a lot of syphilis new testing. And so they will come in, they do trainings alongside me, they do training standalone, and then we are putting Narcan into people's property. Once they come into custody, we identify that they are opioid users. Some of these individuals decline to keep the Narcan, so when they're leaving custody, they will push that Narcan back across the desk at our deputies, and so then we reallocate it and give it to somebody else. But that does happen as well. So we try to provide as many access to resources in those harm reduction, because we know that they are probably, in many cases, going to continue using. So they need to know where to get safe supplies. They need to know how to get the things that are going to keep them healthy. And a lot of them have no idea about what's necessary to keep their bodies healthy. So having them have those conversations about STI testing, hepatitis C, and where to get that ongoing care is incredibly helpful as they are moving forward. Okay, so this is our data. We started keeping track. I had to go all the way back to the end of November in 2021 to get our documentation going. But our most common substances we're going to be seeing are fentanyl and meth, as almost always. It is very rare that somebody comes in and they are not also using a stimulant. It is primarily methamphetamines or clear. They're almost always IVing meth and smoking fentanyl. They smoke a lot of the powder now, which was not quite as common, but we are seeing a lot of powder. We're seeing a lot of blues still. The IV fentanyl powder, they're trying to IV that. It is not water soluble, so it's not working out as they had hoped, and it is causing some injury occasionally. Crack cocaine started to come back a little bit for a while. It is always an interesting resurgence here and there. Every few years we'll see that. Heroin is pretty infrequent. It is not available in the way that it once was, and it is lamented that it is not available, because they will talk about, when I was a heroin user, I had a life. I had a job, I had a family, I could do my business, I could take care of things. Fentanyl has destroyed absolutely everything. So it's a very different game than what we were used to seeing with opioid use. With benzos, street Xanax is incredibly dangerous. We're seeing individuals that are using that. They're losing so much time that they will wake up in the middle of committing crimes and not have any idea of how they got there. It is very, very scary, and we're seeing it a lot. And then we have the danger of xylazine also being introduced into our supply up here in Boulder County. It's everywhere, but it does result in physical injury and a lot of problems because it is not an opioid. It does not respond to Narcan at all. So as of the 26th of September, and these are my yearly numbers, 563 individuals have been identified as opioid users, but 175 of them have been inducted to Suboxone. Whether or not they go on to the next stages is really their call. But we're gonna definitely surpass 2023's numbers, I believe that, because we're only in October and here we are. And this is not accurate because we've added on probably 30 people since I wrote this up. But we keep track of that. So we're keeping track of all the Narcan we're giving out. We're keeping track of all of the individuals that are coming into custody. And sometimes we see the same people like 10 times. And that's okay, because it takes as long as it takes. And if they're with us and they're in custody, then we know that they're alive. Sometimes that's the first step, is this person is still breathing, and now what can we do to help them? It's very challenging because our systems, in the way that they're designed, are not friendly for consumers. And so many times people don't get help or anything until they go to jail, which stinks. But that's always, the challenge for all of us, I think, in working in this field, is that we recognize that there's constant barriers and there's constant things that are coming up and changes, and we push through anyway because it matters. These are people's lives. And that is all I have. And we have questions.
One over here. Thanks so much for that presentation. I'm curious, does this induction process differ if you have a woman who's coming in who's actively pregnant?
So when people are actively pregnant, it's not different because they're safe to receive Suboxone. And so they are mindful of it. We do not transition them to Sublocade or an injectable. Our doctors don't permit that. So they do stay on Suboxone usually, yes.
I just want to comment, I had some unfortunate, not my personal, but family member experience with the jail before this time, and there was no JMAP program, and it's really nice to see how far you've come.
Thank you so much. Yes.
And forgive my ignorance, this is my first year at BCH, but I feel like for Denver, they would send them to a hospital that has like a locked jail thing where we could give the court-ordered medications. Do you guys have like locked jail, nurse run, like almost like an inpatient-y thing? Because obviously I think when you send them to behavioral health at BCH, we also wouldn't have those capacities that I'm aware of. Or is there a plan to try to bridge that and get locked jail inpatient treatment so we can give the court-ordered meds?
Denver Health is Denver County's jail provider, and so it's associated. It's through Denver. Yeah, so it's partnered with an organization that has. So they have. I believe Denver County has a full program. So we.
That would be amazing. Whoever's listening.
We would love to be able to support people with severe and persistent mental health in a meaningful way while in custody. We've seen the magic of antipsychotic medications, and so it would be lovely to see that in our facility, and it is not on the
Wait, sorry. Just so the folks online can hear us. Yeah.
I'm one of the inpatient providers on our behavioral health unit, and when we accept people to that unit, they're on a civil commitment, not in a custody arrangement. So it does differ which statutes we can go through. So absolutely, we can court order meds once they come to us. The problem is they go back to jail and we have to drop the court order. So the only two hospitals that can do that long term are the competency restoration places that they're referring to, where they have a year-long wait. So it's a lot of red tape legally. It's been discussed a lot.
I think on that too, like one of the issues, like what you were just talking about, Rachel, when we send someone to a secure unit, obviously for safety reasons, for safety reasons and HIPAA purposes, there can't be deputies present in the inpatient unit. And so if somebody is, higher acuity or potentially violent when they're unmedicated or something like that, they may not be safe to send there because, it's safe. They should have a deputy present to make sure everyone's safe. So yeah, that would be highly ideal because then, security staff is present, or even maybe a forensic vet at Della Cava. That'd be cool.
Wink, wink.
22 forensic vets?
Yeah, a bunch of them.
We've got time for probably one more question for our jail team. Burning question, anybody? No? Okay. Fantastic. Thank you guys so much. Very informative.